All right. Well, today I'm going to cover our objectives for today. We're going to talk about, hopefully, at the end of today, you'll be able to demonstrate an improved understanding of the DSMES certification process and recognize specific challenges and identify tools and resources, best practices and strategies for successful implementation, and then identify promising practices in implementing an effective DSMES program. In case you haven't heard, I always like to share this in case people have missed. AADE has changed our name. We are now ADCES, the Association of Diabetes Care and Education Specialists. So first of all, I want to talk about what is DSMES. This is sort of an excerpt from the definition in the national standards that I'll be talking about in a minute. But diabetes self-management education support is an ongoing process facilitating the knowledge, skills, and ability necessary for diabetes self-care, assisting the person in implementing and sustaining behaviors needed to maintain or manage his or her condition on an ongoing basis beyond or outside of formal self-management training. And the reason I have a picture of me fishing here is I think it really makes me think of, we're not here to feed people fish, we're here to teach them how to fish. And this was taken in a recent trip to Alaska. So DSMES, I'm just going to give you a brief history of the acronyms because you'll hear a lot of different terms and they all kind of lead to the same thing. DSMT, Diabetes Self-Management Training, is the acronym that's used for Medicare. And it was the original acronym when DSMT was originated back in the, I think, late 80s when it became a more formal thing. And then they evolved to DSME, then DSMES, DSME/T. For a while, it was DSMES, then it was DSME/S. And currently, what we're using is DSMES, Diabetes Self-Management Education and Support. So just so you hear all of these terms, they generally refer to the same thing depending on what someone's used to, but typically we want to use DSMES. So just a quick slide. As I mentioned, I'm a registered dietitian, and I think sometimes there's a little confusion on the difference between what's nutrition education versus medical nutrition therapy. And I think this slide highlights it really well. So DSMES nutrition education is reinforcing basic or essential nutrition related knowledge. Nutrition education does not need to be facilitated by a registered dietitian. So when I had a program, I had nurses and pharmacists that do nutrition education, but they're not going at the depth that I would in a medical nutrition therapy visit. Medical nutrition therapy, as you think of and you look at the iceberg here, is really everything else. And so it's much more in depth, and there's a nutrition diagnosis involved. And so just to clarify, there is a difference between these two things. And I think of it in terms of if you're part of a DSMES program, you're going to be able to educate on basic nutrition needs. But for example, someone with diabetes who also has heart disease or maybe celiac disease, that's when they're probably going to need to talk to a registered dietitian to talk about a lot more specifics in their eating plan and really targeted, individualized things regarding their nutrition and their food. So I'm going to quickly go over the benefits of DSMES. Because there's many, providing the critical education and support to implement treatment plans. So when a person with diabetes sees their physician and gets their treatment plan, we're there to help them reinforce it and really make it actionable in their daily life. We reduce emergency department visits, hospital admissions, and hospital readmissions. We reduce hypoglycemia, all causes of mortality. We lower A1C, promote lifestyle behaviors, meal planning, physical activity, address weight maintenance or weight loss. We enhance self-efficacy and empowerment. We increase healthy coping. We decrease diabetes-related distress, and we improve quality of life, all with no negative side effects and in general covered by most insurance providers. So if DSMES were a pill, would you prescribe it? When you compare DSMES to metformin, for example, sort of the most common first line of therapy when you have diabetes, if you really look at the criteria and compare DSMES to the drug, when you look at it, the efficacy, both of them have high efficacy, low hypoglycemic risk, neutral or weight loss, but DSMES has no side effects. And the cost of DSMES is low or can save the health system money. And then where we really come out ahead is psychosocial benefits. Things like empowerment, healthy eating, making healthy food choices. Metformin can't do that, but we can. So DSMES is based on national standards that are updated about every 5 years. The 2017 national standards, I have sort of the cover page highlighted here. They define quality for programs. So if you're getting ready to set up a program, this is the very first thing you want to do is read this document. If you haven't read it yet, read it. It talks about why we do all these things and the evidence behind all of the standards. So they provide evidence and structure and guidelines for reimbursement. This is the document that Medicare bases their guidelines for accreditation or certification on. And so both accrediting organizations work with Medicare to use these guidelines that we develop to put into place what is required for accreditation. So as I mentioned, these are updated every 5 years, and we're starting the process now. So we anticipate in 2022 to release an update so there will be a 2022 national standards for DSMES that'll be coming out in about a year. ADA and ADCES together collaborate on this. After we update all the evidence, we look at the entire document and we just look at the evidence to support DSMES, publish the document, and then we work with CMS to define what criteria will programs need to meet, realigning with updated evidence. So really thinking about where to begin if you want to start a program. So as I said, read the national standards for DSMES at least twice. When I was working as a quality coordinator, my national standards looked like a college document. I had highlights on everything and things that I knew I had to go back to. And I'll tell you, every time I read it, I learn something new. Or I see something that didn't maybe resonate before and it clicks. So it's really important to keep that document close and make sure you're very familiar with it. The next, and I'll go over this in a little more detail on the next, on another slide, but know our ADCES interpretive guidance. As I mentioned, after the national standards come out, we work with CMS, and ADCES has interpretive guidance that provides more guidance for you on, okay, now what do I need to do? It provides checklists. So you can look at that interpretive guidance document and just check off things. Okay, we're already doing this, so I know I've got this. And it really helps you kind of look at where am I now and what do I need to do? So gather what you have. You take each standard and assess your resources. Think about it. Are you already providing DSMES but just not getting reimbursed? If that's the case, you're really close. You're probably a lot closer to application than you think. Do you have support from leadership to begin the process? That's an important thing in assessing your resources, because if your leadership doesn't see the value and support what you're doing, it's going to be very hard to sustain and succeed. Do you have the right staff in place? Do you have adequate staff to support the program? Do you have space? Right now, everything's virtual, but we'll talk a little bit about this, but most of you might know that, prior to COVID-19, DSMES was CMS or Medicare required that diabetes self-management education and support occur mostly in group classes. So typically you want to make sure you do have space for a group class and or one-on-one visits with a little bit of privacy. Are you set up to bill? Are you going to be able to be reimbursed? If you're not going to be billing for visits using fee for service, do you have another funding source? Are you going to be sustainable? This is not a venture to make you rich. That's for sure. But are you ready? And the other thing is, are you ready to pay the application fee? There is a fee for applying for accreditation. And then how long will it take? Something to think about. Where am I now and how long will it take? So I have another slide that'll go over this a little more, but admin stuff, if you've got just administrative things, you're doing everything else, but you just have to pull together resumes and things, that can take anywhere from 10 to 90 days, depending on your situation. If you're working on kind of fine tuning your DSMES record, and I'm going into a little more detail on that, that can take up to 6 months. So just giving you kind of a sense of the timeline here. So this is kind of what to do and what to think about. So 3 to 6 months before you're ready to submit is when you're kind of putting all these supporting documents together for all of the 10 standards. You're working with at least one participant and putting them through the process. And you're going to start working with your billers to make sure you have things set up and you understand what it's going to take to make this sustainable. Are you going to be able to sustain this and still be able to pay your own bills? Um, and then at the time you submit, once you can log into our software, and I'm going to give you some screenshots of that. But once you log in to start putting those documents together, you do not have to pay until you're ready to hit the submit button. So just know you can open up an application, um, work through the documents, and then you can submit by credit card or check. Um, and then we'll notify you when your application goes into review, and then you'll have a phone interview. So once your initial review's complete, we're doing phone interviews in groups now, and that's where we'll talk about just the process. This is really, the phone interview is sort of the step of the approval process to make sure you understand all the steps that you'll be taking to maintain accreditation at that point. And also to answer any questions that you might have. We'll talk a little bit about billing, a little bit about the annual requirements. So that's really to prepare you for the next year. Now, this is where to begin, just showing you our resources for ADCES. If you go to diabeteseducator.org/DEAP, DEAP, you'll see this big red button, and that's where you'll go. That's where you get to the application. And I just kind of highlighted it here because it's hard to see. I have some vision impairment, so I like things really big. And so this is kind of gives you the picture. Kind of thinks of, okay, all these things we have to do. I try to avoid sticky notes because you can get into trouble, but really thinking of a timeline. So really thinking about, okay, here's where I'm at now. I'm looking at this application. What are the steps? What are the things I need to do? And then we have a lot of resources to share with you. So on that last link, you'll go to, again, diabeteseducator.org/DEAP, and the ready to apply section gives you lots of information. So the quick links at the top, this is where you can access the national standards that I just gave you a snapshot of, our ADCS interpretive guidance. You'll find our pricing here. And then a little bit of information on if you were going to have additional sites. So you'll have a main site for your DSMES program, but maybe you're going to branch out into the community and you have some other locations that you'd like to do DSMES in, and you can do that. That gives you some information there. And then the DSMES consensus report. Um, this was a report that was published in 2020, and this is really helpful as you're building your case for why you need a DSMES program. And it will give you some guidance on some common barriers. And some of the previous slides I shared were highlights from the DSMES consensus report that was published in 2020. Our chart review form, I'm going to show you a little more detail of that. And then we also have an initial application documentation checklist. And next week, this application step-by-step, I actually noticed as I was preparing for this presentation that we need to update that. So that should be updated hopefully by the end of this week. So that if you don't want to click that button and start that submission, what it's going to provide, what it provides you is detailed instructions of the application process and then screenshots of exactly what you're going to be asked for. So you can get everything ready and kind of know what to expect. So this is an example. This is the standard one in our interpretive guidance document. So this is the document that provides really the basis for what you need to pull together for an application. Okay, so this is your main document. I have this printed. I don't print anything. I'm an electronic person, but this is the one document I have printed. I have it on my desk. And when I was a quality coordinator, it was my go-to document. I had sticky notes and things throughout it. So this is going to be your go-to guide when you're applying for accreditation. Both ADCES and ADA have similar documents that guide you through the process. So just to give you, what is this telling me? So as I mentioned, the national standards from 2017 is you see on the far left of your screen, national standard. So standard 1 relates to internal structure. What you're seeing there is a direct excerpt from the national standard. The provider of DSMES services will define and document a mission statement and goals. The DSMES services are incorporated within the organization, large, small, or independently operated. So that is what it said in the publication. And then the next kind of section over, this is essential highlights. And this is pulling highlights from that bigger document that really hone in on this specific area. The interpretive guidance is how we're giving you a little bit more information. So the interpretive guidance is ADCES's sort of interpretation to how you implement this. So you can kind of think of this as it describes all the things you're going to need. So you look at the interpretive guidance and you move to the right and there's a checklist. So, and this is what I was talking about. So clearly documented organizational structure. What is that? That's an org chart. Most organizations have an org chart. And if you're really small, you might not. If you draw me an org chart, get it signed by someone, that's okay. We're really looking for what's the structure of the organization. I was in a DSMES program that was part of a larger endocrinology clinic that was part of a gigantic health system. And so my org chart really focused on my DSMES program and the leadership in my clinic. And it didn't go through the whole health system because the most important things were my sustainability. And so my endocrinology clinic was within internal medicine. And that's about as far as I needed to go because people understood. So if you're part of a small pharmacy, your org chart might have 3 names on it. I have programs that are huge centers and it might be really complicated and we have to really scroll and I zoom in to see what's going on, but it's just an org chart. And so then you can see this checklist, you can say, okay, do I have these things? And as you gather them, you check them off, which helps you kind of prepare for the application and know when you're ready. And this is the tool that is approved by Medicare. And we have other tools and resources to share and happy to answer any questions throughout the process, of course. So I'm kind of giving you a summary here, and I'm not going to go through the standards one by one. I'm giving you a general overview of the things that, as we talked about with this presentation, is really covering where the things that people have the most questions on and what do you need to have? What do you need to pull together? So things to think about are, do you have staff that you need? In order to have an accredited or recognized DSMES program, you need at least one credentialed professional instructor. It's usually a registered dietitian, a registered nurse, or a pharmacist. At least one person on the team. They're going to be performing that initial DSMES assessment to really get a sense of the person and what education they need. And then at that point, that person is going to oversee the plan. Now that can be one and the same as the quality coordinator as well. Some programs have a quality coordinator who's also the instructor. Other programs may have a quality coordinator that isn't an instructor, who oversees a lot of the administrative side of the program. But the quality coordinator, regardless of if they're the instructor or another individual, they're going to oversee all aspects of the DSMES program. They have to maintain that the documentation needs are met. And we're going to talk a little bit about documentation, but if you think of electronic medical records, they're going to be going in and doing periodic chart audits just to make sure everyone is documenting all the things in case you got audited, that everything's there, that you're doing everything that's required in the standards. They're going to compile data from the program participants to report to their accrediting organization. And then they're going to submit annual reports and respond to audits from the accreditation organization or from Medicare. And then you're responsible for communicating with us. You'll be our point of contact if you're the quality coordinator. And you're also responsible for communicating with stakeholders. And we'll talk a little bit more about stakeholders. Other considerations, though, when you're thinking about staffing is who's going to schedule your participants for your sessions? How billing? Do you have a billing mechanism set up? Do you have someone to support you? Do you have a way to find out if when you bill, are you actually getting paid? That's really important. Electronic health record templates and reports. You'll want to think about, do you have those? Can you make those yourself? Are you going to need help with that? Do you have IT support, especially in this day and age with all the technology we have to use? Do you have space for group sessions? Do you have private space for individual sessions? And HIPAA. HIPAA applies to us in DSMES. So we have to protect personal health information. And so you need a locked cabinet or a secure electronic medical record. So now let's talk a little bit about the target population. And thinking about what you're thinking about here is one, who's coming to your sessions? How many people do you anticipate will come? How far do you think they'll have to get to the room? You know, I had a classroom that was about a quarter-mile walk from the parking lot. And so we had to think about that. And when we were scheduling appointments, we had to let people know in case they needed a wheelchair or assistance getting to the room. And that often happened. Um, and so thinking about what languages are most common. What if they have vision or hearing loss? Can you meet their needs? Will you still be able to work with them? Do you have accommodations for wheelchairs or other medical equipment they may bring? So my office was in a very back corner of where we were located. So when I saw people that had a wheelchair, I couldn't see them in my office. So I had to shift things. We had to figure out, which room I'd be able to use when that would occur. And that was just the location of my particular office. Our other offices were very accessible. So things to think about. Do you have chairs big enough for your participants? And are you assessing literacy and numeracy? So one thing is when you're looking at your target population, we are looking at demographics and CDC data for sure. But I also want to know, you can print something off the CDC website and say, this is my county and this is who I hope to serve. But what I really want to know is who? Who are you serving? I live in Virginia. We have a very large military population. So it's very possible that I could set up a program and only serve the military. Maybe not. Maybe I'm serving anyone with diabetes. Maybe I'm serving Medicare beneficiaries. Am I seeing people with prediabetes? Am I seeing people with gestational diabetes? So that's what we're looking at target population. You don't have to overthink it. You can even just write it out. This is who we anticipate serving, and this is the need in our community. So the curriculum. Next, I want to talk about the curriculum. And so what is a curriculum? This is somewhere where a lot of people struggle. So I'm going to start with what a curriculum is not. I'm going backwards through my slide here. A curriculum is not a series of educational handouts or booklets. It's not a PowerPoint presentation, and it's not a required set and cadence of educational offerings. What it is the evidence-based foundation that covers the key content areas that you will be covering in your DSMES program. It guides the content and it gives you some ideas for how to do the facilitation, how to facilitate, some instruction methods, right? It's the backbone of the individualized education plan to base on their concerns and needs. So keep in mind, the curriculum doesn't mean that, okay, we start at 1 and end at 10 and everybody goes through this series. I think of the curriculum is it's everything that's in my brain so that when someone comes in with diabetes to talk to me and they ask me any questions, this information is here so I can help them. It's not to reiterate the information, it's helping me find a way, I have this information to convey to my participants. And I've highlighted some of the most common evidence-based curriculums. So we have the Living with Diabetes conversation maps on the upper left. That is now an interactive virtual program. And I know there's a cost to it. There's a cost to all of the curriculums. On the top right is the Diabetes Care and Education curriculum from ADCES. Our third edition was just released in December. And so that's the one you want to get if you're purchasing now. And the curriculum books range, I think, between $100 and $200. I don't have the exact cost, but they're under $200 typically. They're big, thick books. And the whole team should be utilizing it. Life with Diabetes is another option. Life with Diabetes is a series of teaching outlines, and it's a really question-based curriculum. And so it kind of provides a series of common questions you'll get, and then some answers, some typical answers. So it can be helpful. And then Type 2 Basics is from the International Diabetes Center. So these are the most common DSMES curriculums that I see in use these days. So now you've got your curriculum, the whole team's reviewing it, kind of reviewing in detail the things that they feel maybe are weaknesses. So as a dietitian, when I began, I think the medication section was the section I focused a lot on because that was where I felt like I needed a little bit more guidance and information and content. So now it's time to get support. When you apply, we do ask for a letter of support with your application. Typically, that's going to come from whoever you report to. I reported to the medical director at our clinic. And so my medical director wrote me a letter of support, but she also encouraged me. She said, no, I want you to get a letter of support from the head of the department, the internal medicine department. It was a smart idea because they really were the ones that were making ultimate decisions of our department. And so I'm on their radar now. Every year I actually sent them the letter to re-sign because she thought it was important that they understood that we were still working. So I think that can be a good practice. But then you're going to be needing stakeholders. And stakeholders are people in your community who are going to be a champion for your program. So some examples of stakeholders could be people who are going to promote referrals to your program. They could be community members, or they could be physicians who are really supportive of your program. You've worked with them. They know you do a great job. They're really happy with the results after they send their patients to you. And they could be a good physician champion and someone who could be on your stakeholder group. People that are going to promote participation, advocate for your program, link you to local resources, and provide you with feedback and support. You're going to find these people, like I said, referring providers. Maybe you need help with billing, find a billing specialist. Local religious leaders, people with diabetes from the community. It's really good to have someone with diabetes who's been through your program. They're going to give you some enlightening guidance. Now, the participant record, I'll move on. This is, typically within your electronic medical record or maintained in a secure location that is locked, and you are required to maintain these for 6 years. It's a comprehensive DSME assessment that'll guide the plan. So you work with a patient, you meet them, and you find out, okay, what do they need? What are the key needs today or right now? And you're going to set up a plan. These are the sessions that we think we need to cover. These are the topics that you'll need. And this can change over time, but you start off with kind of a initial plan. And then you're going to need templates to kind of provide some structure to your documentation so that when you send a letter to a referring provider, or the patient looks at it, or even the referring provider reviews it, they can quickly see what happened, what was covered, when they came to your session, who taught the session. We're looking at how did they do? Did they get it? Are they comprehending the information? Are they setting goals? We want to see the goal. We also want to see, did you follow up on that? It's easy to set goals at every session, but we need to follow up to see how people are doing with those goals. You need at least one clinical measure, such as A1C, weight, or blood pressure. A lot of you will be tracking that anyway. We just need to see that you're looking at that. And then you need to communicate back to that referring provider and let them know how your participant's doing. The comprehensive diabetes assessment includes health status, psychosocial adjustment, learning level, and lifestyle practices. This slide gives you kind of an overview, and this is probably the thing that's most unique to DSMES and the thing that you really need to focus on when you start a program. Are you assessing these things? How and where? It doesn't mean you have to ask all these questions. The person might come into your federally qualified health center and the medical assistant's asking them all of these questions and documenting these. So what I want to see is, where do you go to find this information and make sure it's current? So remember, it's making sure you're looking at these things and aware of these things and asking the person if you're not sure, or if the information you have is maybe outdated, you need to verify. And the AAD7 self-care behaviors are kind of the basis for that behavior change, where people can focus on healthy coping, being active, healthy eating, taking medication, problem solving, monitoring, reducing risk. So this is sort of the basis for the goal setting and for the curriculum, the ADCES curriculum. I'm not going to spend a lot of time on our chart review form because I know Anna is going to cover it in more practical manner. But we have this form available, and this is this is your guide, okay? So if you're getting ready to submit, we actually need to see screenshots of your documentation. So if you use an electronic medical record, I need to see exactly where you're documenting and what you document. But you have to de-identify it. So you have to make sure I can't see any protected health information. I am not a provider of the patient, so you're going to need to make sure that is probably the most important thing. De-identify, have 2 or 3 other people verify that there is no protected health information before you submit your application. I can't say that enough. And this form is used as a key. As I mentioned, when you look at that, the assessment, where are you finding the relevant medical and diabetes history? And so you can use this form to say, oh, this is found in this section of the chart, so that if you were to get audited or when you provide your chart, the one chart to us, this is going to map it out. So it's kind of your map key. So as you print up these, however many pages that chart is, after all those visits, you might have a 10-page chart that's got all kinds of information in it. And what we're asking you to do ideally to expedite things is point to me. So circle something and say, okay, this is number 1. This is where the referral is. And show us where those things are. That tells us that you know what you're doing too. So moving on, ongoing support is really important. The impact of DSMES interventions lasts about 6 months, and it's necessary for people to continue and thrive. So it's just what our programs are required to do is help our participants identify a personalized support plan. Do they go to a website? Do they go to a peer support? There's plenty of peer support things online. And we have a podcast here. There's a link in the slides for you to review a little bit more about this. But we really want people to sort of maintain that support, to keep motivated, to stay healthy, and to continue the behaviors that they started. And finally, we're almost near the end of this process, is a CQI project. And I tell you, keep it simple. Quality coordinators, if there's one thing we all have in common, we're very detail oriented, and we tend to overthink things. And so I encourage you, just pick one project. You're probably doing a lot of things all the time. You just need to pick one and write it up. You're just reassuring us that, yes, we're looking at these things. We're aware of quality. And there needs to be data related to it, and it should be specific to your program. Pick something important to you. I'm not looking for anything specific other than that you're looking to make your program the best it can be. And in order to bill, I'm going to zip through this quickly because I want to make sure Anna has plenty of time. But to bill, you do need to be a Medicare provider if you're planning to get reimbursed by Medicare, and you have to be a Part B supplier. So if you're a dietitian already providing MNT, then that counts. And you have to have accreditation or recognition, accreditation by ADCES or recognition from ADA in order to bill those G codes. And then you inform your Medicare administrative contractor, you just send them a copy of the certificate, and that initiates the billing. I'm going to, again, I'm going to kind of move quickly here, but the Medicare providers who can sponsor with their NPI number are registered dietitians, doctors, PAs, nurse practitioners, and then you can see the other 3, but we don't see those too often. And then entities can also apply. This means someone saying you can use my billing number in order to provide DSMES. Hospitals, private practices, FQHCs, a lot of times they're going to use a practice NPI number, not an individual's. And these are the places where that can be done. And there's different methods for every different type of DSMES. So we've made it. It felt like a little bit of a marathon there, I think, but again, just to recap, read the national standards for DSMES at least twice. Know the interpretive guidance. Check off the standards that are in place. Note those that aren't. Make a plan to implement the missing standards. Implement them. Complete at least one complete DSMES record to submit with your application, and get your required documentation for all the standards, and you're ready to apply. And there's the link. Here's a another slide with some of the resources so you can get to them. And I'm going to turn it over to Anna now.
Thank you all so much. I apologize. As many test runs and technology kind of run-throughs as you do, there's still some things you can't plan and prepare for. So thank you for bearing with me as we get started. But as I was mentioning, in our care, this is our main location. We have over 40 clinics and locations in our care. We are branching into Mississippi, but we do not yet have a diabetes program there. We have 2 locations and hope to add that as another existing site down the road. And in Kentucky, we have 6 locations with a separate existing accredited diabetes program. Next slide, please. And just to give background about our organization and our team, we have a coordinated care team, which is really our education and wellness department. And over the past 2 years, we've tremendously grown. We have registered nurses, dietitians, clinical pharmacists, LPNs, diabetes prevention coaches, and we have some other staff that are non-clinical, such as telehealth facilitators, billing and coding staff, and community health workers that really all pull together to make up our team and our program. Now, we most certainly didn't start out with all of this staff, but we've been able to grow over the past 2 years. And on the right, you'll see the range of services that we as an organization provide to our patients. We have everything from the diabetes self-management, education and support, to continuous glucose monitoring, to pharmacy consultations. But today, again, we're just going to focus on the DSMES aspect, but I think it's interesting to see just the variety of services that we offer and provide, and kind of how that all links us back to DSMES. Next slide, please. So just to kind of show you a little bit of the history of where we've been and where we are now, kind of the comparisons and the contrast within the last 2 years. Our diabetes program was accredited 2015 to 2016, and at the time, we had approximately 6 to 10 educators. Our team consisted of nurses, dietitians, and clinical pharmacists. We had 1 CDE and 1 board certified in advanced diabetes management, which was our pharmacist. And at the time, everybody's roles were split into multiple duties. We didn't really have a full dedicated team committed just to diabetes education. Everyone wore multiple hats, which had its pros, but it also had its cons. Fast forward to 2018 going forward, our team total does still fluctuate, and we are growing and expanding, but we have 13 committed educators just to our diabetes program. It's a combination of nurses, dietitians, and 4 of which are CDCESs. And our job duties really focus just on the diabetes piece, except for our dietitians, which do cross over and provide additional medical nutrition therapy. But initially, we did just kind of have to split out and cover a little bit of everything everywhere. The growth has let us really hone in to kind of specialize in that area. We previously were maxed out at 30 branches. Our main site in Augusta, Arkansas is where it all started. And from there, we were able to add the additional locations to offer and provide the service to our other satellite clinics. And now there is no longer necessarily a strict limit on how many branches you can have off of your main site. So that allowed us to establish sites at each location that we have a clinic at. So we've been able to grow and expand our reach. But again, this all started in 1 clinic with 1 location. And as the really just it kind of caught on and patients began coming and other providers and clinics saw the benefit, it grew tremendously and very, very fast. And we had a lot of support behind us for this. Our mode of delivery is something that's also really dramatically changed. We previously did all in-person, face-to-face clinic visits. Now, fast forward, we have a blended approach of face-to-face and or telehealth. And we'll talk a little bit more about our telehealth challenges, successes, and some information of how we've navigated that. The format of our program and sessions is something we also dramatically changed as well. Previously, we always did one hour one-on-one session with all participants, and then we filled the rest of their time with those remaining hours in group sessions. One thing that's unique about an FQHC is that we do have a little bit more flexibility of providing more sessions in that one-on-one setting. So we have transitioned since to doing pretty much all of our appointments and diabetes sessions one-on-one. And we do still have a couple existing group classes in locations that really just had a strong presence of patients, a strong pool of participants that were committed and attended regularly. And also when we have couples that may come in together for education, we can structure that as a group class. But other than that, we transitioned to the one-on-one format. And that really helped us with our scheduling. It helped us provide more availability and options. And again, with few educators covering such a large area, it gave us more flexibility for the timing of visits. For completion of the program, we initially struggled to really complete our patients. We didn't necessarily have as clear of a definition as we had hoped to for when is somebody done with their initial year of diabetes education. We know that they get 10 hours that first year, and that's a once in a lifetime benefit we most certainly encourage them to use. And we knew that we were going to cover all 7 self-care behaviors, but it was a little bit subjective and hard to, we were just saying that we weren't really completing patients in the program at a high enough rate and what we thought we were really doing. So fast forward again, and we kind of redefined what completion of the program meant for us. And these are our minimum qualifications that we as an organization set to define those that have completed. So if a registered nurse is providing the education, that consists of 4 separate DSMES visits. If the service is provided by a registered dietitian, it's still 4 visits, but we slip in the medical nutrition therapy as the second visit. We want to make sure that those patients with diabetes still get access to a dietitian for that medical nutrition therapy visit. And so if they're seen by a registered nurse, they certainly put in, they collaborate with the provider to get that referral and follow up with us on that. So that's our minimum requirement. 4 sessions, must cover all 7 self-care behavior topics. Some individuals may go longer, and that's certainly fine, but this really helped us to improve really just the continuous follow-up and making sure that we're following up with our patients well. And just some other things that we've added to our program. We had the addition of a professional CGM program just this last year in collaboration with our clinical pharmacy team, and it's been an excellent, excellent resource to our patients. We've had some really great improved outcomes and have been able to really tie that in very, very nicely to our DSMES program. Next slide, please. Our process, just to kind of show you what it looks like in order for us, we begin with most of our referrals come in-house from our primary care providers, and they refer to us in our EMR. However, we do still see patients outside of our organization that don't use us for their primary care or as their clinic. So we accept the outside referral along with requested paperwork to make sure we have all documentation needed prior to the visit. Our coordinated care scheduling team is the one that's responsible then for making contact with the patient to schedule the visit based on the educator availability. We try 3 times to contact patients, and then after that third failed attempt, we'll send a no contact letter and give them 5 to 10 business days to call back and schedule before we close the referral. We want to make sure that we can get a hold of these patients in any way possible that they need to get them in. The appointment is then made at their preferred clinic or location, or at this time virtually, just again based on their preference and our availability. We have the appointment, we relay the education back to the primary care provider, and then we continue to follow up as needed with that patient. So that just kind of outlines a brief recap of our structure of how we obtain referrals all the way through the end of follow-up. Next slide, please. For telehealth, we've actually began our very first telehealth visit in December of 2018. And for us, as a large organization covering, at the time, 30 plus branches trying to offer our services there with very few staff, it really was a necessity to be able to reach these clinics, both from a time perspective and a financial perspective. And at the time, we partnered with another organization and used a platform called Cisco WebEx. We have since grown and seen a dramatic boom in the telehealth services. We have telehealth organization-wide, so it is not just for our DSME program, it's for all services that we offer, but our educators are all trained and are set up to use this platform. So patients now have the option to be seen, whether that is in the comfort of their home or in the clinic if they prefer. Prior to COVID-19, when we did telehealth, patients had to be in a clinic. So we would connect clinic to clinic. We may be 3 hours away across the state, but we would make sure that when they presented to the clinic for their visit, they would still be triaged, all vitals would be obtained. That's just for our preference and our records. And then the facilitator, which could be a clinical or non-clinical staff, would assist with making sure the participant had all the education materials they needed, whether that was an education booklet, food models to assist with the session. So there was really no discrepancy in the quality of care they were receiving. But telehealth has been such a wonderful resource for meeting patients where they're at. and something we're excited just to continue using and growing with. Next slide, please. The EMR documentation. As Sasha mentioned, this chart audit and review form is so critical and important. Not only does it help you internally to see areas for improvement, but it also helps you from the accreditation standpoint and is an absolute must. I would encourage you all to familiarize yourself with this and use this on a regular and routine basis. This helped us determine, first off, what do we need to track? Second, what do we want to track? Are there additional things in our EMR that we as an organization want to keep up with as well? It's important to get input from your educators in terms of what they need for efficient and easy documentation, but still making sure they have all aspects there to make it individualized. We have providers that give input because they are the ones reviewing and reading over notes, so figuring out what they want to see in a chart note. Getting input from IT or anyone who's helping either build or adjust or make changes to your documentation form is very, very critical. We've continued to modify and adjust many, many times as we've changed EMRs. We actually just underwent a change in 2020 to a Greenway product called Entergy, and got the chance to really rework our documentation form and systems. And this chart review audit form was the basis and the guideline and the foundation for how we outlined our structure of charting. So I would encourage you, if you have an existing program or you're beginning, do internal chart audits. This is the best way to provide that feedback and facilitation for educators and to help improve ways to track and document information. Next slide, please. So this is a snapshot of what our EMR document and form looks like for charting. It does seem a little bit long. I know it may look a little overwhelming initially upon first glance, but I like to think of it in 3 sections. The left is our initial assessment. The middle section is really where all the education happens. And the far right are our SMART goals and follow-up. And so I won't walk through every single one of these points, but I'll kind of highlight a few key important critical things. We document at the top whether it's a group, initial, or annual session. We assess their healthcare beliefs. You may notice the big, bold, yellow highlight under health literacy screening. The reason this was highlighted at the time when I took this snapshot out of our EMR, we were making a change and adding this into our notes. We had an organization-wide health literacy screening that was used, but our team wasn't quite incorporating that as routinely as we hoped. So we put it in there, highlighted it in yellow. That way it would draw our attention to our educators until they became comfortable with it and no longer it was kind of the forgotten missing piece. We assess their learning styles, reading, writing, hearing, any vision problems they may have that can impact the session. And then we have some additional room for the individual assessment and documentation. In the middle, we list our 7 self-care behaviors to make sure that we are tracking and keeping up with these. We assess their level of understanding of the education we provide. And then really focusing on the far right are those community resources, linking our participants with additional resources in the communities and other programs to help with that support piece. Our recommendations to PCP. And the self-report, we don't necessarily fill that out upon the first visit. When they come back, we like to track and see not only are they meeting their goals, but are they reporting making positive changes based on those 7 self-care behaviors. So that helps us from a data and tracking standpoint, but also an educator standpoint as well. Next slide, please. And these are just a few snapshots from this free text box within the notes. So you can see on the far left, this is where we document their lab values, which gives us the clinical measures that we need to track and assess and see if they've made changes or improvements. And again, that comes straight from that audit and chart review form. In the middle, this is where we do our individualized assessment. Previously, we really just had a big blank text box. And it worked for some, but not well for others. And what we found is if we would include these prompts in there to help our educators and our team have a really consistent workflow, we had much better documentation and charting. And so again, these prompts come straight from that form. Everything from their relevant medical and diabetes history to diabetes knowledge, diabetes distress, and cultural influences. So it gives us that chance to really hone in on the individualized piece. And then on the right is just a note where we sign our name so we can see who performed the visit under the PCP in the clinic. Next slide, please. Our education materials, as mentioned, the curriculum is key. It's a foundational piece for your program. We use the ADCES curriculum We do have education materials that we've created in-house to support that based on the curriculum, and that are just quick handouts to individuals. So our diabetes education books cover 7 self-care behaviors and kind of have just some brief highlights and snippets. They're all made on low literacy, I believe it's 5th grade and below reading levels for our adult learners. We try to use a lot of other visual tools in the program just based on the patient's needs and desires and their learning styles. That's why it's so important to assess that. So everything from glucose wands to play images, food models, glucometers for teaching, carbohydrate counting charts, and really any supplemental material that's going to aid that patient with the education that they need. Next slide, please. And so I just wanted to include here just a few very brief resources. Again, ADCES, wonderful resource. I can't say enough great stuff about their staff. They've helped us as an accredited program. I answer questions along the way. The Academy of Nutrition and Dietetics also has great resources, particularly if your organization has any registered dietitians. And then at our care, myself and Emily Cooper, our Director of Coordinated Care, her background is in billing and coding, and she's been a wonderful resource to our department and team and is always happy to help answer questions. I believe there may be one more slide. Okay, and yep, that concludes it. So